And this is Sophie. I'm actually going to talk to you about health assessment and physical examination. This is in chapter 31 for nursing fundamentals. And why do we do this? What's the whole purpose of health assessment and physical examination? And honestly, the biggest reason why we do this is to establish a baseline, to evaluate patterns of change, and then to see what therapies or treatments are going to be prescribed based on that change, and then to be able to evaluate a patient's response and outcome to that change, to that treatment and therapy based on our assessment. So it serves a very fundamental purpose in everything we do in nursing. So as you guys are going through, this is a Kahoot. You can actually do this on your own to study as well, and Takar may have you do it in class. Again, why do we do a physical examination? We may triage for emergency care. So what does triage mean? That's when you're doing a quick assessment to ask the patient, can they breathe? Are they, hemorrhaging? Are they bleeding? You're looking for high risk problems that may be happening. So it can be used for triage for emergency. It can be used for routine screening, right? We all go for our yearly physicals. It helps to establish a baseline, and then it helps to identify anything that is trending away from baseline. People often need a physical examination for health insurance, for military, for you guys need it as a nurse. Anytime we admit a patient, whether it's to the hospital or long-term care facility, they need to have a head-to-toe assessment. And that is actually a quality measure that is hospitals are held accountable for, because why do you think we need a head-to-toe assessment on every admission to a hospital or a long-term care facility? We need that to determine, what if all of a sudden someone has bruises 3 days later? Were they there in admission? Right? We need to have a head-to-toe assessment on admission, because we need to be able to evaluate response to treatment and what's changing. So that's huge. So that's one of the things we're really going to work on this summer in lab and in clinical, is you guys are going to learn how to do a head-to-toe assessment. As you move further through your clinicals, you're going to learn much more focused and in-depth assessments. You're going to learn how to listen to all the different heart sounds, and you're going to learn how to do a more in-depth neuro assessment. What we're going to be focusing on in fundamentals is how you can do a quick bedside head-to-toe assessment that really takes, not very long. We're looking at 5 minutes, 10 minutes to do, this head-to-toe assessment. Again, very different than when you're doing focused assessments. In OB, you guys are going to learn how to do a focused OB assessment. So someone who is admitted to the hospital in labor, they're going to have an initial head-to-toe. And then honestly, from then on out, they're really just going to have their focused OB assessment. That head-to-toe assessment is there. It's on the chart. It's documented, because if you didn't document, you didn't do it. Why is it so important to document assessment? So you can see if there's change. That's the only way to know. If I'm a nurse and I go off shift and you come on and look at your patient and you notice one of the biggest things we're looking at is changes in skin integrity, and you guys are going to learn about that as you guys learn about, I think you guys learned about that last week. It's a really big deal if a patient gets a pressure ulcer in the hospital or in a long-term care facility. It can affect how they're reimbursed. It is a quality measure and metric that is tracked. It can actually be considered negligent. So you better be darn sure that you did a full head-to-toe assessment on admission, so you can show that no, that actually was there on admission. So again, I've gone through all of this stuff. You guys can certainly read that. I'm not going to reread it to you. Here's a quick quiz. Okay, so you're meeting a patient for the first time. It's important to establish a baseline assessment that will enable a nurse to refer back to. What do you guys think the right answer is? So if it's a baseline, would that be the physiological outcomes of care? Well, no, not necessarily, right? Would it be the normal range? No. When meeting a patient for the first time, you establish a baseline assessment that will enable the nurse to refer back to a pattern of findings identified when the patient is first assessed. So a physiological outcome of care, that's going to be the ongoing assessments that you do. That's going to be more of your focused assessments that you do based on the treatment plan that is described. The normal range of physical findings, there's no way to know if it is going to be a normal range of physical findings. You're doing a head-to-toe to find out what that patient presents with. So you want to find out what their pattern and what changes from what they were first assessed with. You need to establish a baseline. And not clinical judgments made about a patient's changing health status, because that would be someone is short of breath and you go in and you do a pulse ox. That's a focused assessment based on their changing care. That's a triage assessment like we talked about before. That's totally different. A baseline assessment is that initial assessment done at admission to help identify a pattern, a finding, and a pattern of those findings, and you can see when it was first assessed. We always need to think about cultural sensitivity when we are assessing a patient. Certainly, we want to be careful to avoid stereotyping and making assumptions. So for example, you want to consider health beliefs. You want to, make sure that you ask people about alternative therapies. It can be incredibly uncomfortable for some patients to be undressed. And so you want to really respect that and pay attention to that. You always want to consider their privacy and ask, do they want this, is it okay if this person, is there for that? So it's really important that you always think about patients' cultural beliefs and their cultural sensitivity when you're doing techniques. You guys need to know these words. They are in red. They are in red because you need to know what this means. You inspect with your eyes. Inspection is the first thing you do. You look before you touch. I always say I can do so much of my physical assessment just looking at a patient, just walking in a room. Are they sitting up? Are they laying down? Are they moaning in pain? Do they look blue? Do they look oxygenated? Do they look like they're gasping for breath? Do they seem confused? Are they happy? Are they smiling? Are they out of it? Are they staring into space? Inspect. Look at your patient. So much of physical assessment is done by looking. Palpate then as you actually feel, right? So you actually feel palpation. We're going to learn, especially with focused assessments. You're definitely going to learn palpation with focused assessments and a little bit in our head to toe. Percussion is something you're going to learn more with a focused assessment. It's when you take your finger and then you're on one hand and then the finger on the other hand and you actually tap it over different organs, and it helps to show you the border of the organ. Does the liver look enlarged? Do you hear something? You percuss over the lung fields to see if, it's a way you could maybe identify a dense area or something that's a little bit different. I will be honest, I don't think percussion is used very often in nursing, but you need to know what it is. And then auscultation, you're going to do that all the time. That's listening. Okay, so I always would say the order would be look, listen, feel. Because if you palpate someone's abdomen, you want to listen before you touch it, right? Because you don't want to disturb something. But you palpate their abdomen for areas of tenderness. You'll definitely do that in a head-to-toe assessment. So inspect, look, listen, feel. Know what all four of these words are. Understand what percussion is. If you need to Google that to look at a video of it, understand that. And it helps to either find masses or it helps to identify if an organ seems bigger, if the border as you percuss it will sound different to percuss over the belly than it will over the liver. And again, this is something you'll get in lab when we're going through lab. So again, when you inspect, these are all the things you want to make sure that you're doing. You're looking for symmetry. Is the side of the face drooping? There is just so much information that can come from just stopping and looking at your patient. When I would take care of fresh C-section patients, so the first day post-op, and I would get them up into their chair to sit, and I would make their bed. And I love to make the bed at that time because I would be talking to the patients while I was doing it. And I always say, don't forget, there's a lot of information you can get from making a bed. Was there blood in the bed? Was it wet from the patient sweating? Was the patient so still that the sheets weren't even moved because they were in so much pain? And then getting that patient up to the chair. Were they dizzy? Can they tolerate it? Can they talk to me? So much assessment is happening during those sort of what we used to consider tasks, but they're really not. If you can, as a nurse, if I can instill anything into you, A, it's flow, right? Always look at your environment. Your environment affects healing. And then B, it would be how much information can be gained doing tasks. And I know many of our nursing aides are going to make our beds, but it's don't ever think that there isn't so much usefulness that can come from doing that. Ambulating a patient, getting a patient up to a chair. If you have time, don't delegate that. If you have time, do it with a patient because you can learn so much when you do that. Again, you're going to have these full PowerPoints so you can read the notes, the notes underneath. Here's palpation. again, okay? You use touch to gather information. You always want to warm your hands. Who wants someone to go in and like deeply go into their stomach, right? We've all had health exams. You lightly palpate someone's stomach and then you go a little deeper to see if they're feeling pain, okay? Percussion, again, you guys can read through all this. I talked about it. Auscultation, you want to have a good stethoscope. When you put on your stethoscope, you always have the earpieces out. So like they can either bend in or bend out. And I always look at it as I want to hear you. So if you're not sure how to, listen to stethoscope, it's I want to hear you facing you. So they go that way, not towards you. And again, I'm going to let you go through and listen to this. But again, you need a good stethoscope. You need to have practice. You need to hear things again and again and again. I don't know if you guys will remember, but in nursing 190 and 191, we talked about Brenner's stages of being a nurse, and it goes from novice to expert. You cannot expertly determine crackles as a novice nurse, okay? Our goal is to get you up that scale a little bit so you're not a novice nurse when you graduate, but you're sure as heck not going to be an expert. And I've always done OB. I have a very hard time hearing different heart sounds. I learned it. I had to learn it again when I got my master's, but it's not something I've had to do a lot. When I listen to a heart and OB patient, mostly what I'm listening to is for regularity and rate. And so, Takora, who's worked in cardiac quite a bit, she is going to be much, much better at that. So it's a kind of skill that takes time and practice. So please don't expect that you're going to be an expert. It's something that takes time. We listen to heart sounds. We listen for lung sounds. We listen over the trachea for what we call bruits. You can use the bell for that part. You use the diaphragm or the bell, which is a smaller part, for different things. And again, I want you to go ahead and read the notes under this. I don't like to read to people. So a general survey. This is what you do when you look at a patient, right? Isn't that the first thing we do? We're going to look at our patient. We call that a general survey. In red are words that I think you may not know that I want to make sure you know, because those are going to be words that show up on tests. Affect is your mood. What's your affect? A flat affect is someone who just like is nothing, like their face shows nothing. Maybe someone who is crying, right? They seem to have a sad affect. Gait is how you walk. Is their gait steady? Is their gait shaky? Is their gait imbalanced? So gait is how someone should walk, and someone should have a, steady, balanced gait is what would be considered normal. So whenever you do a general survey, you are getting a ton of information about this patient. Substance abuse, what might be signs of that? Track lines that you see in the arms, right? Maybe you have a patient come in and you actually, we know that people who use meth can often have poor teeth. It affects the teeth and actually leads to decay in the teeth. Again, you don't know for sure, but things you're thinking, this may be something that's showing us. Body odor, are they well groomed? A child that comes in that has, doesn't have good hygiene, has body odor, isn't groomed well, has bruises. There's a lot of information you're getting just by looking. And you want to be careful not to make judgments and not to make assumptions, right? But to understand these are things that warrant further investigation. So it's okay to question, in your mind, could this child be abused? And then you investigate further to determine if that's true or not. Okay, so your general survey is what you do when you first just look at a patient. Okay, so I want you to make sure you understand those terms. And then you do your vital signs, right? And in a baby, and adults, you do height and weight. Those are just very basic baseline information that we're getting. You're going to go through, so this is going to go through a head to toe. You're going to look at skin, hair, and nails. And again, I'm not going to read this all to you. You guys can read it. But cyanosis would be blue skin. That would be a sign of something was wrong with oxygenation. Jaundice is yellow. Someone's skin looks yellow. That's something could be wrong with their liver. They have this buildup of bilirubin. Is it erythemia? And that's redness. Okay, are they burned? Do they have an infection? Why is it looking, have that redness to it? So what that person is doing to that patient's skin is they're pinching it. It's called skin turgor, and typically we do it on the back of the hand or over the sternum, and that shows us if they're hydrated. okay? It shows us a hydration status. It should not tent. It should bounce back, okay? So that's skin trigger. So these are things we're looking at with skin. You're looking at hair, right, for all of these different things, and I'm going to let you read through that. You're looking at nails. All different kinds of things can show us. Someone can have, if you guys have ever seen someone who has clubbed nails, where it's kind of rounded, that can actually be a sign of an oxygenation problem. Hint, hint, you may see that on a test. Clubbing of the nails, and honestly, I'm not sure the pathophysiology of why that happens, but someone who has clubbed nails, it can be a sign of an oxygenation problem. You're going to look at all different kinds of things on the nails that show you what may be going on. And actually, I'm going to let you go ahead and read through all of the notes underneath this because there's a lot of great information. Head and neck, right? Does it look normal when you look at it, right? Can you, so again, this is doing a very thorough head to toe. We're going to learn how to do a bedside head to toe assessment that you really can do in a few minutes. But, and then you will definitely learn very detailed focused assessments. But, you can palpate that TMJ, that joint right on either side of the ear and the jaw. Does the skull, when you feel it, do you feel any bumps or lumps? Does it seem the same? You'll learn to actually feel for different glands behind the ears and along the neck. You guys are going to learn how to evaluate someone's eyes, okay? So the lacrimal apparatus, that's where you have tears, right? That deals with your tears. Your corneas, okay? Some people can have a cloudy cornea, and so you're going to end up looking at that too. So again, you also are going to learn what we call perla, and that means pupils are equal, round, react to light, and accommodate. And that is something you'll be doing in your baseline head to toe assessment, okay? That's a very quick NUR check that we can do. So you turn off the lights and you have a pen light. So for clinical, you guys will need a pen light. And you shine the pen light into each side of the eye. Are the pupils equal? One's not big and one's not small, right? Or are they if they're like pinpoints, that can be a sign of a concussion. Okay, so are the pupils equal? They should not be different sizes. So that's the PE, pupils equal. Are they both round? A blown pupil where it's lost that round shape, the black part, it is a serious sign of a neurological issue. Do they react to light? So are pupils equal, round, react to light? So when you shine the light, it should cause the right and the left one to constrict at the same time. Okay, so do they react to light? So you'll look at the one side as you go in the other, then you'll go on the left side and make sure you see the right side, and they do that at the same time. And do they accommodate? And so if I take my finger, and you'll learn this in lab, and I touch the finger to my nose, okay, and I bring it to you, and I bring it back, we should see your pupils get smaller and bigger. As my finger goes farther away from you, your pupils get bigger. As they go closer, it gets closer. So pupils equal, round, react to light, and accommodate. Perla, you need to know that by heart, okay? And it will go through, you can read everything underneath it. You're going to look at the ears. You will learn how to look in ears. That is not something you're typically going to do as a nurse, more if you were to become a nurse practitioner. But you want to look for symmetry, all of those kinds of things. In newborns, sometimes skin tags and things in the ears can be signs of birth defects. So we always look at the ears. Are they equal? Are they low set? Are they the same size and shape? Is there a discharge from it? Are they painful if you touch, part of them? That can be a sign of a infection. So again, different things you're going to look at. What you need to know is in red here. This is very important. So again, this is fundamentals. We're giving you an overview. Read through all this. Anything in red and terminology, I want to make sure you understand. Look, listen, feel. I want to make sure you understand that. But as you move along through your nursing courses, you're going to learn more focused assessments. But one of the things you need to know is when you are looking in someone's ears, you pull the auricle, so that's the top part, up and back in an adult, okay, to straighten out the ear canal so you can actually see the eardrum, and it should look clear, or it's kind of like gray and shiny. Shouldn't be red, it shouldn't be bulging, it shouldn't be leaking. For infants, you pull it down and back. And so someone said up, and away as you grow older, like up, and away is one way to remember that versus down and back, but they almost always ask that question on a HESI. So I really want you to make sure you understand that. Sinuses, we have these sinus cavities. You guys took A&P all throughout our head. So people who have a sinus infection are going to have soreness under their eyes in those cavities. Also, usually, they'll press on top of your eyes, over your eyebrows. Someone with a nose, you want to look and see, do one side, can they breathe in? Do the other side, can they breathe in? Is one side occluded? When you just basically look, you can see, does it look like there's a deviated septum? That septum is that middle part. Is there drainage? Is it look really irritated and excoriated? You can tell someone who has a bad cold. I'm sorry, I'm touching my nose as I'm talking. Mouth and pharynx, again, hydration is huge. Your blue lips, that would be, that's a big deal. Cyanosis, you're going to be worried what's going on from a respiratory standpoint. Hydration, are they dry, right? Do you see any lesions? Is their mouth and tongue dry or white? Sometimes on a baby, white can actually be a fungal, like a yeast infection from breastfeeding. Lots, and again, just looking at a patient, open their mouth. Can they stick their tongue out? You're going to learn that's a sign of a neuro, that they're neurologically intact. So again, looking at their gums, especially when we have older patients, do they have dentures? Do they have them with them? Are they in their mouth? Do they fit appropriately? Do they have teeth that are loose, or teeth that are rotted? Have they not had dental care? That can cause lots and lots of pain. Not having dental care can actually lead to abscesses that can be incredibly dangerous. So lots of information, can come from that. The thyroid is, I'm going to be honest, this is something that would take a lot of practice to feel. It's not something you're going to do in a head to toe assessment at the bedside, but we can practice it on each other. And basically you can read how you do that and you'll learn that in lab. I want you to understand these different types of breath sounds. When you go through, what we call normal breath sounds are bronchovesicular and vesicular. That's just normal. Crackles is this sort of, it sounds like crackles, like, oh gosh, that cereal, snap, crackle, pop, kind of can sound like that when you, on inspiration. So inspiration is breathing in. Rhonchi is almost like, like when someone has like a cold and they're trying to cure it. It's like rhonchi. Wheezes are when your airway is constricted. This is someone who has asthma and it's like that. Okay. And then a pleural friction rub is something if someone has like an irritation going on or some sort of infection. And this is something you're going to be able to practice in lab, but I want you to understand what these things mean. Okay. And just kind of read through and try to understand that. Crackles is a sign that like pneumonia can be setting in, to be honest. But what you're going to be doing typically when you listen to breath sounds is, are they equal on each side? Are they clear? Can you hear them throughout all of the lung fields? Okay. That is signs of, that they don't have pneumonia or cough or something setting in, especially post-op. It's super important to be identifying lung sounds. Wheezes, really important. Is there an obstructed airway for some reason? Are they having an asthma attack? Are they having an allergic reaction to something? This is a serious problem. If someone, is all of a sudden developing wheezes, you need to figure out why. So again, we're just introducing you to this. I want you to be familiar with the terminology. Okay. Someone is admitted with pneumonia. When osculating the patient, you hear low-pitched continuous sounds over the bronchi. These sounds are labeled as rhonchi. Okay, rhonchi are loud, low-pitched rumbling sounds heard on, you guys know what the bronchi are. Those are the big tubes. Okay, crackles are going to be down more in the alveoli. The bronchi are what you hear, in the big tubes that separate between the two. Okay. All right, heart. Again, you're going to learn a very focused heart assessment as you go into cardiac. So I'm not going to go too much into it. But you want to hear that lub-dub, right? So we want to hear the heart constrict and relax, and constrict and relax. And when it constricts, it's pushing blood flow. When it relaxes, it's filling, right? When it constricts, the ventricles are pushing blood flow throughout your body. And when it relaxes, they're filling from the, oh my gosh, atrium, sorry. So you can go ahead and read through that. Okay, I don't want you to get too much into heart stuff other than you're hearing extra heart sounds. You're listening for murmurs, which is when there's sort of backflow of blood in some of the valves. Again, I am not someone who's really good at hearing murmurs. There is what we call an S1 and S2 split. And again, this is something in clinical you will get more practice with. So what I really want you to get when you do a basic head to toe assessment, what you're listening for is regularity, rate, okay? Is it regular? If it's irregular, it needs to be investigated further, okay? And you need to let the doctor know. Do you hear murmurs? And, I often possibly would hear a murmur, but I wouldn't be able to necessarily differentiate the different kinds. And then the doctor, oh, murmur heard on auscultation and admission. Great, the doctor knows they need to investigate that more, okay? So I don't want you to go down a rabbit hole of feeling like you have to memorize this, but I would like you to read through it and take away that murmurs are graded from a quiet to, they go from grade 1 to grade 6. Some murmurs they can actually feel, okay, or you can even see it looking at someone's chest, which is why we always look, listen, feel. The point of maximum intensity is a part where you can often even feel the heartbeat, and it's kind of right under the breast. We'll show you that. But what I want you guys to understand is auscultation is how we assess a baseline heart rate and rhythm on admission, and what we're looking for are dysrhythmias, any extra sounds, murmurs, which is caused by the blood flow like kind of going back up through the valves from the ventricles to the atrium. And the PMIs is point of maximum intensity, where you can actually feel the heartbeat through the chest and hear it the loudest when you auscultate. S1 and S2 is something that you are going to learn how to hear in lab, and Takora is much better at that than me. But it's all very interesting. So how do we assess the vascular system, right? Blood pressure, right? One of the first things we're going to do is look for blood pressure. You're going to look and see, does it look like they've distended jugular veins or carotid arteries? Do you see the neck pulsing? That's all concerning, okay? You listen, that's the bell of the stethoscope, and this is really cool. A bruit is when it's like those vessels are narrowed, and so the blood is trying to push through it, and it causes this like it's called a bruit sound. And so you actually listen with the bell over each side, okay, of the carotid artery. And so we know if someone has a clot in the carotid artery, what's going to happen? They can have a stroke, right? So, and again, you're going to learn more about that. So your takeaway from this is a bruit is something that you can hear over the major arteries that would show that there's some sort of blockage happening or narrowing happening. But one of the biggest things you want to do in a head-to-toe assessment is see, is the blood flowing peripherally, right? So we feel pulses, right? You feel the pulse in each arm. Is it equal on each side? You feel for pedal pulses, possibly popliteal pulses, which is behind the knee. Why would you feel a popliteal pulse? Maybe this patient had a femur fracture or something, right? And we want to see, is that blood flow flowing? Whenever someone has a cast of any type, or has had any kind of ortho surgery, it's very important to be feeling pulses below the site of the surgery or the injury to make sure that you're not having any sort of what we call compartment syndrome or swelling that is cutting off the circulation and can cause gangrenous tissue. If the blood flow doesn't get to it, you're going to have tissue injury and it's going to die. So that is one thing you will definitely be feeling for pedal pulses. And we use a scale of 0 to 4. 0 being you can't palpate it at all. And sometimes then you have to actually get a ultrasound and what we call Doppler for it, and you'll be able to do that in lab. 1 is you can't really feel it very much. 2 is normal. 3 is bound, it's increased, and then 4, it's bounding. Why would someone have a bounding pulse? They have fluid overload, right? Something is going on. Why would someone have a barely palpable pulse? Sometimes we even use the word thready, and it's hard to feel. Maybe they're super dehydrated or they're hemorrhaging, right? So there's a lot of information that can get from the pulses, and you need to know if on admission, this is why that head-to-toe assessment on admission is so important, because maybe they came in with a very thready, barely palpable pulse, okay? So this isn't a change. This isn't a pattern you're identifying. This is what they were admitted with. So do you need to, call a rapid response. No, this is what their pattern has been. It's been identified. The doctor is aware. So again, this is why it's so important we accurately document our assessments. And again, these are just different arteries and pulses you can feel, and this is showing you how to do that. It's going to go through all the different arteries, femoral pulse, popliteal pulses behind the knee, and then you have your dorsal pedis pulse. Okay, so they're going to go through all of that. If you can't palpate a pulse, you need to actually use an ultrasound to make sure that you can be certain that there's blood flow going to those peripheral arteries. Okay, you're also going to be looking, is it pink, right? Is the skin pink? Is it blue or molted? That would be concerning. And then you do what's called capillary refill, where you're going to look for what we call varicosity. So we all know vein, right? That's like varicose veins and things like that. Did they come in and on admission, or is it new? That's important. Is there edema? Edema stands for swelling. You need to know what that word means. Pitting edema is when you actually put your finger, you push it down where the swelling is, and you pull your finger up and it sticks there and you can see that fingerprint. That's called pitting edema. They are third spacing fluid in that tissue for some reason. 1+ edema, 2+ edema, you grade it 1 through 4. And again, I'm going to have you read the notes underneath this. Varicosities are when you have, phlebitis is when you have an infection actually of a vein. So people can get phlebitis from an IV. So it's really important when you give an IV, okay, thanks, Nolan. It's really important when you give an IV that that you check and see, are there any signs of phlebitis? Erythema. What was that? Arrhythmia. I say erythema, but I think it's erythema. But that's redness, right? Those are all signs of infection. Redness, heat, swelling. And then you're going to inspect and auscultate the belly. When we do an assessment, we do it head to toe, right? You do it in a systematic, organized fashion. You come in, you talk to the patient. Hi, I'm Sophie. I'm here to do your initial head to toe assessment. Talk to me. How are you feeling? Are you in any pain right now? It's huge to assess pain during this, right? Pain is what the patient says it is, and we're going to talk about that in a little bit. But you do your head to toe assessment. So you start with the head and you move on down. So now we're at the belly. You look before you listen, okay? You look and then you listen, because if you listen, and you want to have looked first, because once you auscultate, you're actually like pushing the belly around. So you begin with inspection and then you listen and then you palpate. Okay. So look, listen, feel. Look, listen, feel. You look at the skin. Does it look like they have a hernia of the umbilicus? That's a belly button. Is it symmetrical? Does it look distended? We all have bellies. We know what our stomachs can look like. Does it not look right? Peristalsis, do you guys remember what that is from patho or from physiology? That's the peristalsis is how your organs move all the food through your stomach. It's the muscle movement of your stomach and your intestines. If you have decreased peristalsis, you're going to have, what do we call it? Constipation, right? Anyone who has surgery has decreased peristalsis. The anesthetics we use for surgery paralyzes our bowels, okay? You can also have bruits because you have major blood vessels that go through your abdomen. And so, AAA, right? When someone has an abdominal aortic aneurysm, that's a huge emergency. So you're going to listen to that middle part over the belly with the bell to see if you hear any bruits, which would be a sign of some sort of constriction. Kidneys, you're going to feel over the back part, and so we'll talk about that. The growling sounds that you hear when you're hungry, that's that peristalsis happening with nothing in it. I did not know this. They're called let me pronounce it right. Oh gosh. Borborygamy? I'm not sure, but that was on a test question, and I had no idea. I'd never heard of that before. But that's that stomach, your growling sounds. So when you palpate, you last. Look, listen, feel. Look, listen, feel. All right, so you're going to palpate last. You always start light and then go to deep. And again, we're going to, you'll talk about that in lab. What's the first skill you do? Come on, you all know this. Inspect. Look, listen, feel. Inspect. And then you're also going to do a musculoskeletal assessment, right? So you're going to look at how they can walk, what's their posture, looking at their back, looking for scoliosis, right? Kyphosis is like those old people who have, like goes over. Lordosis is what happens when you're pregnant. It's like that weight, they have a sway back, sometimes it's called. So you can just look at someone and see, oh, they have lordosis, which is fairly normal when you're pregnant, right? Lordosis is fairly normal. Kyphosis is you know what, I hate to use the word hunchback, but it is that's how it's described. Why are they kyphotic? What's going on? Is it old age? Is it some sort of injury? What's happening? And then scoliosis is where it's like crooked, where the spine isn't in a linear thing, it actually curves. So these are all things you can get by just looking at a patient. You're going to learn to do range of motion, and we'll talk about range of motion. There's active range of motion and there's passive range of motion. Active is the patient can do it. Passive is you do it for them. Why do we do range of motion on patients? Because we want to maintain their muscle tone and strength as well as assess their muscle tone and strength. We're looking for hypertonicity. Someone who's rigid, right? We've seen that. Hypotonicity is someone who's very, very like jelly, and then atrophy is very weak. It's like their muscles have atrophied. So by doing passive range of motion, we can keep by stimulating that muscle and causing it to contract so it doesn't atrophy. And then we look at doing a neurological assessment. And I don't want to get too much into doing this. We'll be doing mini mental status exams when you're in psych. But what you want to know for head to toe is the big thing we're looking at is orienting to person, place, and time. Okay, so hi, can you tell me your name? Hi, yes, I'm Sophie Bowerman. Do you know what day it is? Yes, it's Tuesday. Well, I might during this pandemic be like, is it Tuesday? Actually, I don't even know what day it is today. It's Monday. Oh gosh, I wasn't orientated to time. Do I know where I am? Yes, I'm at home in Downers Grove. It's 2020. So we do want to orient to person, place, I'm sorry. You want to orient to time. You want to orient to person. Do they know who they are, and place? So oriented times 3. Some say 4. It kind of depends at what they're looking at. So again, you're going to learn how to test for all the different cranial nerves, but we're not going to go into that right now. That is a very in-depth neurological assessment. Balance test, right? Did they have balance? Are they able to, the Romberg test is just a simple one where when their eyes are closed, you have them put their hands straight at their side and stand on one foot and then on the other. Are they able to do that? That gives you a lot of information. You'll notice a lot of our patients as they get older are not able to do that. You're going to test reflexes. So we are going to learn that in fundamentals. Again, we're using a 0 to 4 scale. There's no response or there's a brisk response. Someone that's brisk is, hyperactive, or clonus is when the foot actually goes up and down. But the patellar reflex, you've all had that, where they take the knee and they take the hammer and they do your knee under the patellar. If it kicks up really fast, that's really brisk, okay? That's a little bit faster than suspected. Maybe for some reason someone's hyperactive, and it can be that their electrolytes are off or their certain medications cause that. SSRIs often cause reflexivity. I'm not sure I'm saying that right. Okay, so again, reflexes, you need people to be relaxed, and you want it to be the same on each side. And so we'll get to practice this in lab. The problem with reflexes, if people think about it, they often lose their reflexes. So one thing you can do is have patients take their hands and put them together and try to pull them apart. And if they concentrate on pulling their hands apart instead of on their knee, that will often help. And we actually test for reflexes often in OB because it tests for a condition that actually causes increased CNS, central nervous system problems. So it's actually something in your OB rotation, you'll learn a lot. We test for reflexes every time as one of those focused assessments. So the last thing I want to talk about is pain. We think about pain as a 5th vital sign, right? So you've got respirations, temperature, pulse, blood pressure, and pain. Most places are going to use a 0 to 10 pain scale. It is so important on assessment that you get a baseline pain, because how can you assess what's happening if you don't have a baseline pain when they came in? And it is what the patient says it is. And then you also want to qualify the pain and quantify it. So how long has it been happening? Is it dull? Is it an ache? Is it sharp? You want to try to get those words to quantify what the pain is. When I started as a nurse in the 90s, and Takora, I'm sure, would agree with this, anyone who rated their pain as a 4 or above, we treated with actually Norco we would offer. Well, lo and behold, what happened? The opioid crisis. And we found that maybe in our sort of trying to really be on top of people's pain and understanding pain is what people say it is and treating it, it went a little overboard. And so now we've realized we really can't just be using opiates off the bat. And so now they're doing a lot of research on pain with looking what we call using like a multimodal pain approach. So you try to go different pathways. So we know that cold and heat can help with pain. Cold and heat it's that gate control theory of pain. So when you use cold and heat, the nerve that is going, the signal going to your brain to tell you you're in pain instead feels the cold, right? So that's that gate controlled theory of pain. So we may use cold, we may use heat, massage, right? Distraction, slow deep breathing, because we know when people are anxious, they feel more pain. NSAIDs like ibuprofen, Advil, Motrin, those are all NSAIDs, Toradol, that work on swelling from pain. Acetaminophen is Tylenol, and that can address different pain receptors, as well as now we look at like gabapentin, which looks at like nerve pain. So in the past, I'd be like, here's a Norco. Now we know that post-op, patients often do need an opiate for a short period of time, but very soon after, we need to really start looking. If a patient is having burning pain, that is nerve pain. They need something like a gabapentin, not just a Norco, right? We need to be weaning off the Norco and trying to very much address the type of pain, the quality of the pain, and how they're feeling it. And then using this multimodal approach to try to sort of come at that pain from a whole bunch of different ways. And really, that's sort of one of the target things that pain specialists are doing to help decrease, the sort of opioid epidemic that we've had. So there you go, health assessment in a nutshell. I really look forward to working on this with you guys in clinical and lab. And remember, read through the slides. I'm going to post them on Blackboard so you'll be able to see the notes underneath. Read through the slides. Save this in your folder because this is a great review for when you're studying for the HESI. Make a folder in your computer that you save things that are a good review for when you're studying for HESI and boards and things like that. But know that the focused assessments, so a much more focused neuro assessment, a much more focused cardiac assessment, OB assessment, mental status exam assessment, these are all things that are going to happen as you move through your med-surg courses. So again, you are novices right now. We're trying to move you up that ladder a little bit, but we know it's going to take some time. So I hope you all are doing well. Thanks for listening.